Hello, I'm David Murphy, the 2019-20 President of the British Psychological Society. This is the second of two parts of a discussion I hosted with three other members of the group that developed the BPS Guidance on psychological needs of healthcare staff during the coronavirus pandemic, and a number of healthcare staff from a range of different backgrounds. In the first part, I outlined the stages of psychological needs of staff during the pandemic, and the group talked about some of the different emotional experiences of staff and the importance of peer support. In the second part, we will talk about patient care, particularly in relation to end-of-life care. So please do be aware that you may find some of the content upsetting.
Poignant, really.
Yeah, sure. This isn't an experience which is at all unique to me. This is happening up and down the country and the world every day. At the last clinical shift I worked on, there was a patient who sadly was moving towards end-of-life care. And of course, in those circumstances, it would be absolutely be involving with their family or their close others. And in this circumstance, for various reasons, that wasn't possible. So it was left to a bedside nurse who was not a critical care nurse, and myself, to go through that part of care with this patient. But also there were some fairly specific requests, entirely reasonable, from the family. Please can you hold their hand? Please can you play some music? A very specific song actually. And there were some practicalities to doing that. But for me, that was probably the closest to that part of end-of-life care that I've probably been in my career. The paperwork is neither here nor there, but that was very different. And I guess the role I was playing, in reality, it wasn't so much to comfort the patient, because actually the patient was deeply sedated and sadly going to die. It almost felt that my role was there to comfort the person who wasn't there, actually. The family, and to ensure that the things that they felt would be helpful were done. So I guess the questions I have for the group really are some of the issues about going through that. And after the event, I felt that I needed to recontact the family member shortly after, almost to provide assurance that those things were possible and those things were done. And I don't know if that's right. I don't know a better way to go about it.
Well, I think that's absolutely right. And it was really touching to hear you speak about that and see you write about it. In the guidance, we talk about the fact that relatives' well-being, patients' well-being and staff well-being are all interlinked. You can't think about them separately. And also connecting with some of the fundamental values in providing care. And I think your example there just really shows how you can connect with our fundamental values about providing care, even in, by being sort of creative and doing things differently. And so to me, that sounds like a really good example of doing that. And my contact with other people, and particularly speaking to people in other countries who were really overloaded. I spoke to someone in Spain or Italy, the hospital was so overloaded and they just couldn't do that. And relatives were dying but patients were dying without their relatives there, without even being the relatives knowing or even being able to tell the relatives till some time later. And the staff will really, that catches up on the staff. It really has a cumulative effect on the staff. So I think, that to be able to do what you did, I think is so important. But I'm sure other people will want to come in there.
It reminds me of that notion of a good death and the impact that has on the cumulative grief, and that if the healthcare professional and or the relative actually perceive it to be what they call a good death, which is usually nice and controlled and calm and everything's neat and tidy. I put that in for the ICU nurses because that's what we like. Then that's somehow easier to deal with. And what you just described happening in Spain there was very much the opposite of what we perceive to be a good death. And I worry that then would have quite an emotional impact on the nurses caring for the patients, and indeed, of course, the other professionals, the doctors and the AHPs, that if possible, ensuring that good death could help everybody concerned. How we do that, I don't know.
Anybody? Karen, and then Sean.
I just think this happens on such a bigger scale than what we would normally deal with, because in intensive care you might have maybe 1-2 patients die maybe a week or so. So you don't, you could go weeks without being actively involved with either withdrawing treatment or enabling somebody to die peacefully. This happens every shift now, and you basically have to take the place of that family. Because they can't be, sometimes they can't be there. And I know people are trying very hard to get at least one family member in, but normally we would have it open to anybody that wants to be there. And this happens, on a regular basis. And that's quite hard to try and take the place of that family and family members to be able to provide that, like Louise said, that good death for the family and for that patient.
I think what we see, and I've seen in examples in other countries and here, when people, is that a little bit of care can go a long way, and that knowing that somebody cares, even if the relatives aren't able to be there, knowing somebody cares, I think, can go a long way, and there are ways of being creative, which we talk a bit about in the guidance. Sean, did you want to come in?
Yeah, I mean, intensive care units are very used to end-of-life care, but when we do it face to face with touch, and we listen to them and try and honor what they want, and we do things in front of them, even if we think they're slightly unusual. Doing it this way makes it feel almost completely unemotional, if you see what I mean. The idea of talking to someone over a telephone or over a video conference, in the back of your head, you're sitting there thinking, surely this isn't the right way to do it. And yet it's the only way you can do it. And I've seen it from the deaths that we've had, that there is a lot more discussion happens afterwards about how people felt about it, because it's just so alien. The idea that we can't even go in and touch the hand of the relative the patient's died, it's a really difficult concept to do, and breaking that news over the phone or the video where you clearly, sometimes the relatives are elderly or their first language is in English. You don't realize how much just being able to see your whole body language and see your and physicality is so important in doing that.
I was just thinking, you can't even make them a cup of tea.
That's what we rely on a lot, isn't it?
Normally you would make them a cup of tea. You can't even give them that basic care.
We can't even let the priests in for a lot of them. It's and quite often, part of my normal discussions are, what kind of religious beliefs does the patient hold, and is there anything we can do at the end of life you think he would have approved of? And we can't get Muslim clerics in, you can't get rabbis in. A lot of them aren't safe enough to be fit tested, for example. And most units don't allow anyone in. We've started allowing the ones closest to the patients to come in now, but quite often they don't want to come because they don't want to spread any kind of disease. So that whole religious aspect of it's just gone. Boom.
Sean.
Yeah.
Yeah. I have to say that I think the more that we can find out about what the person would have wanted regarding prayers or religion or music or whatever, the better, really. I've spoken to a number of relatives by phone and tried to find that out, but also said, do you have a message that you'd like me to pass on? And then very often that's been very emotional for the relatives. But I have felt the need then to go back into the room, or to pass a message on to somebody if they're gowned up and I'm not, but to say, this is really important. This message needs to be passed on, and when we document in the notes that we have passed on the message, and tell the nursing staff to tell the relatives also that we have passed on that message, because it's the, I don't know if, you know, even if we can't get the priest or do the right prayer, there's something about there being some kind of connection with the relative that's fundamental, I think.
I do wonder about asking some of these questions as the person comes into the hospital at the front door, when they're not on death's door, so to speak. So when we going to the A&E department or the acute medical units and start asking those questions, because not everyone who comes in with COVID will die. We have had success stories of people actually leaving. So maybe it's about asking the questions at the right time. What would you like if? But then that then causes a whole load of other problems. People may think you're asking me now what I'm going to do when I'm going to die. You're not going to treat me because you think I'm going to die. So it gets kind of a bit messy.
Karen, do you want to go?
I think we're quite in a unique scenario. Well, I don't have to say that, but you know, we're in a scenario where everybody knows that if you get admitted to hospital, there's a big chance that you're not going to do well. There's a big chance you might end up in intensive care. They know that the family and things can't come in and see you, which is, we've never been here, because normally if I see somebody in A&E and they're really sick and we're about to intubate them in A&E, I would actually, if I can, I would get that family in to come and see the patient before I pop them off to sleep, because I know that there's a chance that they might not see them awake again. And, you know, it's having those conversations with people in intensive care. You know, what does your family member like? And especially as you go down the route of that, you're looking towards end of life and things. And we're so used to doing it face to face. But now the whole world knows what happens to some extent when people go into intensive care. And I don't think we've ever been in that scenario. And people, I can't imagine what the patients feel like when you say to them, we're about to take you into intensive care. And your family is not even there. I made somebody the other day face call his wife, because I called her and she was absolutely distraught about the fact that we're admitting him to intensive care. And he's like, oh, no, I'm fine. I don't need to distress. I said, no, really, you need to speak to her, and things. And it's just, we're in such a unique position that I don't think we've ever anticipated we were going to be in.
Because the last time these families see their patient is when their ambulance door has been shut. Yeah. And that's the memory that they have. Because my mother got admitted 2 weeks ago, and that was the last memory that my dad had, was that ambulance shut. My mum's now got home, but all my dad could talk about was he just saw the ambulance door shutting, and that was it. Which is why doing things that you just said, Karen, is actually really important if you get them at the right time.
And I think even, I'll come to you in a second, Rachel. I think even if it is the last visual memory you have, I think that knowing that something happened, like a message was passed on, can really help that adjustment process for the relative as well. Because you know, it might be the last memory, but you've also, your mind's obviously thinking about how were they when they died. And so, you know, these little things can make such a difference. Rachel, sorry, do come
in. We're just hearing that same story time and time again. People are, you know, practically walking into A&E with us from the ambulance, and families aren't getting a chance to properly say goodbye, and they don't want to distress their sick relative by saying goodbye. And then, you know, in a matter of hours, those patients are on intensive care, and it's the same story, and it's very unexpected for everybody. Despite the fact that this is all we hear on the news, despite the absolute bombardment of information, we keep hearing the same story, that people are fit and well, and then they go downhill very, very quickly, and they don't get that chance to say goodbye.
And it's sad that, you know, people were making these, it's like you do with kids, you give one person the heart and the other person the other heart to keep that connection. It's having that string between the two family members. And then you get infection control that says, oh, you can't do that because, you know, you're taking something into an area that's not clean. And it just breaks my heart that we can't even do the basic kind of things to try and keep that connection between the family and their patient and their relatives.
really stressful for everyone, for the patients, for the relatives, and for staff as well. And I think it adds for staff particularly to some of the kind of moral injury, feeling helpless, feeling like they're not able to control things, feeling that wouldn't be what I would want for my family member. None of this is how things are usually. And I think there will be a lot of people who afterwards will want to make some kind of reparation for chances that they missed to say goodbye, or to be able to visit an intensive care unit and see where their relative died, or talk to staff who may have been involved in their care. So I think I think where you can prepare people and where it's practical to do that is good, but I'm a little bit cautious as well about not giving more expectation on staff that they have to enable everyone to have a good death. And I know that might sound like a harsh thing to say, but I just think that the reality of the volume of patients and the resource issues and things make that really difficult a promise to keep. And it's really important that we don't have staff afterwards feeling like they're never going to be able to sleep again, or they feel guilty because they couldn't do something that wasn't in their gift. So I think that's just important to bear in mind. Now, I completely understand for relatives how distressing that would be, and saying goodbye to someone is always distressing, even when people have months or years sometimes to prepare for that. It's always distressing, and some of these circumstances will be really sudden and really traumatic. And I don't know whether it's more traumatic to see someone go into an ambulance or to see them in intensive care with tubes and masks and things. You know, you don't want your last image of a person ever anyway. So I think there's a lot of work that will be needed around bereavement support for staff who've had multiple grief and loss, and relatives as well. And some of that we maybe can't, we can maybe mitigate some of that just now, but it's not realistic to say that we're going to do all of that.
I think that's right, Elaine, and I think, I mean, different relatives will differ. I think that's a key point, and some people will want to see them via video link, and some people won't. And we know about coping, it's really important to be sensitive to those differences. But I think another, really within what you're saying is a really important point, that we shouldn't be judging ourselves. No staff member should be judging themselves by the standards that we'd have in a normal time, because this isn't a normal time. We need to judge by the situation we're in. I think that's really important.
The other thing that I feel is really difficult is when somebody has died, having to tell the relatives. So I had to phone up a 92-year-old lady to tell her that her husband had died in A&E. He hadn't been in that long. And she was on her own, socially isolating, no family members, and no, I said, what about the family? But because he was likely to have had COVID, the advice has to be, well, actually, you really should continue to socially isolate. So then I phoned her daughter, and she said, well, can I go and see my mum? And I said, well, you have to decide whether to take that risk as a family. But the advice really is that your mum should socially isolate, and that just so goes against my nature. I found it really hard that I was giving that advice to that family at a time when that family needed to be together to support each other in their bereavement. It's just really odd and unusual and horrible.
Sure, but again, bringing ourselves back to thinking about people that might be watching this. I mean, there'll be a lot of people who might be in the situation that Helen was in there, and I think, it is tough. I think the recognizing that it's tough, it's really tough on the staff. It's obviously really, really tough on the relatives, both in terms of immediately after bereavement and then also funerals. People are not able to attend the funeral even, and I think just recognizing that and that it is so alien to what we would normally do, and that it's okay to feel that that it's not it's not what you want to do, but that actually doing those little things like ringing the mother and the wife and the daughter, can make such a difference. And I guess just focusing on what we can do and the care that all of us came into this, being in healthcare roles because that's what we want to do. We want to, care for people, make them better. And, we are able, to focus on the things that we can do, even though we recognize that it may not be that, all the things that we want to do is a way of coping, and recognizing that, that there will be times when we're not able to do things that we would like to do, and that is going to feel upsetting. Julie?
Just thinking back to kind of experiences with relatives over the years, and I think one of the things that we often feel is that we want to put it right for them in some way. We want to kind of relieve and alleviate their distress, and you'd be surprised at the smallest thing that goes the furthest with relatives. So just a kind word, just saying things like, I'll be there for your loved one at the end. It doesn't have to be as dramatic as we think it needs to be. And I think this kind of these symbols of care and this communication of care it doesn't feel like it as much as we'd like to give, but it goes so much further than you realise.
I think just to finish that case in a way, I called back that relative after the withdrawal of treatment and the provision of simple care, which was no pain, no distress, holding a hand and some music. And actually just knowing that those things had happened from a very simple short phone call, I think was hugely helpful. And more often than not in intensive care, it's assumed that people don't know what has happened because they're often there. And I think this scenario is slightly different. So in terms of a practical point, I think that follow-up phone call, whether it's led by a bereavement team or by teams like Julie's put together for the family contact team, I think that is something pretty impactful actually, to say the things we talked about did happen. They did die. There was somebody there with them. They were in no pain or distress, and now they have died. I think that in itself would be hugely valuable, actually.
Absolutely, I'm sure. Resham, did you want to come in?
Yeah, I just wanted to say it might be really important for people to recognise who within the team wants to make that phone call to say the patient has passed away, and that might be really beneficial to that team member. That might be important for them as a part of the care that they have delivered that patient. And so it might just be worth checking who's going to make that dreaded phone call.
Yeah, no, as we were talking earlier, I think this really kind of highlighted to me that these things, they can't just work on individual sort of, acts of compassion. They have to be embedded into the system, and it has to be a team, people working together. So I think that's such an important point, Resham. Is there anything else people want to say about this sort of relatives end of life care before we sort of move on? Sean, did you want to come in?
Yeah, two brief things. First of all, we traditionally tend to let the more senior staff do the breaking the bad news things. You have to be mindful of that, because doing too many in a day is very, very draining. And having that after the first conversation, I tend to get to, by the time I do my third one, I can't do anymore. I mean, I physically have to turn around and go, I'm sorry, can somebody else have this conversation for me? So what we started doing is we tend to do them, but we have junior nursing staff and junior doctors watching, listening, and sometimes we'll flip it over and let them do the conversations while we sit and listen and provide support in that way. But we need to make sure that it is hugely stressful, and that we spread it out as much as we can. But we have to be mindful of those that we think will struggle with delivering that kind of information.
And I think as well, Sean, that comes back to as an intensivist being very much perfectionist, controlling, and giving yourself permission. I'm assuming it's about giving yourself permission to ask somebody else, will you do it? To admit that actually 2 in a day is too much, let alone 3 or more. Right. So giving yourself permission to ask others and making that the norm, the cultural norm within where you work. And it's great if you've been able to do
That was exactly what I was going to say, Sandy. So I'm glad you beat me to it. No, I mean, and what even more, you're modelling that to others, and I think that's a key thing about being able to monitor your own kind of how you're feeling and act on that, not suppress it, but to say, look, I can't do this, or we're going back to what we were saying earlier about if you're doing things that you just are beyond your competency, just saying, well, actually, look, I can't do this. Well, how are we going to deal with it as a team? And that willingness to communicate and be open and work as a team, I think, is so critical in times of crisis like this.
It's also, as Sean said, it's something that many members of the multidisciplinary team can do. It doesn't have to sit with a consultant doctor. We have nurses, we have consultant nurses, we have physiotherapists, we have a whole team of other people who could help deliver that news. So no one profession should think it should sit on their shoulders.
I would say that it does have to be somebody who's been involved in the clinical care of the patient, because I've been involved in some discussions where they say, oh, we could put that off to psychologists, and I've said, no, I mean, psychologists are good communicators, but it has to be somebody, who can actually speak to the care and convey that meaning about, what happened at the end of life. So, but I completely agree. It doesn't need to be. But
there are still many healthcare professionals who are at that point at the end.
Absolutely, yeah.
But that needs to be made clear, because I absolutely agree with Catherine. But it's quite common that it'll be the senior doctor that gets left with it. We've got very good nurses in my department, so that our senior nurses, our nurse consultants, will take that role on. And especially now that we're so used to the nurse at the bedside giving them enough information, so the only time they ever speak to the consultant is when something bad's about to happen. And that's all changed now. So I think you're absolutely right.
I suppose in this current situation, the something bad is almost expected in some respects. It's not going to be a completely something that nobody that ever thought about, possibly.
Mm-hmm. Julie?
Some of the particular interesting experiences of the family team so far. One is consultants won't give us the news because they want to keep it, so the control thing, and they're not sharing the information. But the other is the families are saying to us, we are expecting something bad, so only ring us when it's bad, or when they've left. So it's really interesting in terms of the variation of what family are needing right now.
And I suppose that goes back to asking, before you get to that situation, what do you want to know? Do you want it every day, or do you want it just when it's happened? Yeah. Good back when people have got capacity to make those decisions.
Right. No, that's really helpful. Okay, I'm conscious of time. We need to sort of wrap up fairly soon. Just that we're out of time. But is there any other issues that we feel we haven't covered that you wanted to cover?
I think we are in a surge to action now, and quite rightly so, in terms of frontline healthcare and providing treatment for patients. But I think from a wellbeing perspective, both of our staff, but also the recovery of those patients who do survive and the impacts, I think we need to make sure that we don't front load this and there's nothing left for later on. And I think that will be the biggest crime of all. And I think that will be the big moral distress and injury, is that if we feel like we get everything, we squeeze everything out of our staff and they're left exhausted and burnt out at the end of this,
right,
and then everyone goes back to normal. And also if we leave our patients in communities without rehabilitation and access to follow up and support.
You've made that point in the guidance really quite clearly, that we're not going to suddenly sort of say, oh, everything's over, we're back to normal. It's going to be a real process of getting back to normal, and and people are talking about we'll probably never get back to exactly how we were before. We'll go on to a different place, but that will take time. Any other points, just again thinking about people that might be watching this, that we might want to kind of summarize and leave people with? Sean?
I think Julie's right. I think one thing to remember is in 3 months' time, the rest of the hospital will kick back off again. Everybody will go back into the surgery, into ED, into the medical specialities, but we will be left with a lot of patients, and I suspect they will still come in reasonable numbers. And they don't stay for a few days, they stay for weeks. And they stay for weeks with high mortality and high morbidity. So your welfare plans have got to address a long, long time.
Right. Thanks, Sean. Anyone else last points? Bob, did you want to make any last points? Again, thinking particularly about sort of healthcare staff that might be watching.
Well, I think I just wanted to emphasize exactly what we were talking about this is very long trajectory, right? And as much as it's really helpful to describe it in phases, they don't announce themselves, right? This is just a kind of continuous process of something that feels much too long and is going to continue to feel much too long for much too long. So I think we need to kind of think of the marathon aspect of this as being our kind of best case response to the normal stress of working in healthcare, which is an occupation that has quite high occupational risk at the best of times. And so that at a system level, not just at an individual level, we're organizing things in order to reduce burnout and reduce injury and keep our people well and benefiting rather than being harmed by the work they do, right? Which we weren't terribly good at before COVID came along. And so there's kind of an obligation or a responsibility, but an opportunity to get better at that now that it's so important that it's kind of rubbing our face in it, so that we can maintain that after COVID's a boring disease.
Okay, well, I mean, I think Bob's point I think is really helpful as well about the marathon. And in the webinar, I stumbled and said it's a sprintathon, and actually I think because it's not a sprint, it's a marathon, and I said it's not a sprintathon. Well, actually, I think it is a sprintathon because you feel like we're sprinting, and then we realise that we've got more to sprint, and so it is about finding ways of coping and adjusting with this situation to the best we can. And I think it's been really helpful to bring our different perspectives together. I feel really great that we've all contributed to this discussion, and it hasn't just been the experts, it's been all of us sharing our expertise. So I really hope that it will be helpful to people watching. I think people will find it. And so thank you to all of you for your time. I know all of you are incredibly busy, so thanks for making time, and I hope it's been useful to you, and I'm sure it'll be useful to other people. So thanks so much, and hopefully I might meet some of you in real life at some point. But anyway, thanks very much for your time.
Thank you, everyone.
Thank you.
Bye-bye.
Good night.
Bye.
Bye. Thank you. Bye-bye.
I really do hope that you found that discussion helpful. If you'd like to access the guidance document or discover more BPS resources relating to COVID-19, then do go to our website www.bps.org.uk/responding-coronavirus, and to view the webinar on demand you can follow the link that's shown on the screen now.